So we can start. Welcome everyone to this public PhD defense of the graduation program that's called Programa de Graduação, Pós-Graduação em Ciências da Saúde of the Faculdade de Medicina da Bahia, Universidade Federal da Bahia. Today's respondent Thiago Cerqueira Silva, who will defend his thesis entitled Digital Health for Monitoring the Effectiveness of Vaccines Against COVID-19 in Brazil. Thiago has performed his research at Fiocruz, Bahia. I am Viviane Boaventura, his main supervisor, and Professor Manuel Barral Neto, that is here also. He is his co-supervisor. I will briefly describe the process for the PhD defense, but first I will introduce the members of the committee. I'm very honored to present the thesis defense committee members that are Professor Dr. Heather Whitaker. I'm calling your name correctly. So she is a doctor in epidemiology and public health in England. Professor Jennifer Dan, that is a doctor in immunology and microbiology from the University of California, San Diego. Professor Cristina Ribeiro de Barros Cardoso. She has PhD in basic and applied immunology and is a professor at University of São Paulo. And Professor Jamary Oliveira Filho, a doctor in neurology at UFBA, Universidade Federal da Bahia. So the process will be, the student will present his thesis. After that, we will start a discussion with the more distant members of the committee, and then I think physically more distant is rather than Jennifer, then Cristina, Jamary, and finally I will talk a little bit. So each member of the examining committee will argue the student for about 30 to 40 minutes, followed by a time for the answers. You can choose if you do the questions and then he answer all of them, or do simultaneously. After that, we will close this section, and then the grading committee will resume for discussion. So in the outcome of the dissertation will be informed for the public lately. So I will now give Thiago the floor to start his presentation. Thiago, can you, oh yeah, it's open.
So, good morning or good afternoon, everyone. Thanks for coming to my defense. I said before, my name is Thiago, and I'm going to present my thesis entitled Digital Health for Monitoring the Effectiveness of Vaccines Against COVID-19 in Brazil. So the SARS-CoV-2 is a beta coronavirus, and the disease caused by it is named COVID-19. And the mild forms of the disease is characterized by fever, cough, sore throat, change in smell and taste, and other symptoms. And the severe disease, defined by the Ministry of Health of Brazil, in the presence of respiratory distress, dyspnea, low oxygen saturation, down to 95%, and cyanosis. So there's active research about the risk factors for developing severe disease, and among them are age past 60 years old, presence of comorbidities, being male, and the other characteristics. These are very important because they only first oral antiviral drug for COVID-19 was approved only in 2022. So there's a very important role for the vaccine in this context to reduce the transmissibility and to protect against severe disease. My next topic is about the country of my study, the Brazil, which is here represented by 3 cartograms. The first one showing the resident population, the second the average household, and the last the number of health professionals per 1,000 inhabitants. We see a very heterogeneous country, and most of the population is concentrated in the south and southeast region. and this region are also more wealthy and more has more health professionals than the others region. The total population in Brazil is estimated to be 212 million, and the Brazil has a unified health system, named the Sistema Único de Saúde SUS, which covers all the population. In aligning the COVID-19 cases worldwide and where Brazil fits in, we see the top 5 countries by number of the absolute number of COVID-19 cases. Brazil is the 4th place in the total numbers, and also the 4th place by COVID-19 cases per million of inhabitants. In addition to that, we can see Brazil had a high test positive rate since the start of the pandemic, reaching values close to 60% during the Omicron wave, and between the ancestral wave, it is always higher than 30%. So it probably indicates a notification of cases in Brazil. Furthermore, Brazil has took a rush tool because the COVID-19, it has a second most number of deaths, close to 700,000 of individuals, but it has the highest number of COVID-19 deaths per inhabitant. As said before, Brazil is very heterogeneous, and it is shown in the COVID-19 cases across the country. We can see the first cartogram showing the cases per 100,000 inhabitants, and the second one, the deaths per 100,000 inhabitants. We see a mismatch between the states with more cases per inhabitants with the states with more deaths per 1,000 inhabitants. And this is probably because each state had this, the health policy to deal with COVID-19. So there is a difference in the burden of COVID-19 across the country. Now let's turn on about the digital health in Brazil, which is comprised by multiple surveillance systems, and then we're going to focus in 3 of them. The acute respiratory illness, the SUS notification, established in the 2000 for influenza and the respiratory virus, the severe acute respiratory syndrome, the SARS, named CVAP gripe, which was established in 2009 due to the influenza pandemic, and the COVID-19 national vaccination campaign, named the SCPNE, and all SARS and the COVID-19 cases and the COVID-19 vaccination must be notified. Talking about the vaccines employed in Brazil, in summary, we have 4 different vaccines from 3 different platforms. We have the Coronavac, produced by Sinovac and the Butantan, which is an inactivated vaccine. We have Shadox, produced by AstraZeneca and Fiocruz, which is a non-replicant viral vector vaccine. We have BNT, produced by Pfizer and BioNTech, which is an mRNA vaccine, and the D26, produced by Janssen, which is also a non-replicant viral vector vaccine. In the timeline of these vaccines in Brazil, the vaccination campaign in Brazil started in January 18 with Coronavac and Shadox, close to 1 month after the first COVID-19 approved worldwide. And among the priority groups for the vaccination campaign are the older individuals, past 60 years old, the healthcare workers, and the individuals with comorbidities. So these 3 groups are majorly vaccinated during the first trimester of 2021. That's it. It was vaccinated with Coronavac or Shadox because the first batch of BNT arrived only by the end of April, and the first batch of AG26 by the end of July. In Brazil, we also had the recommendation of the Minister of Health to administer booster dose primarily with BNT, but also with Shadox or AG26. As the there was a huge necessity for the COVID-19 vaccine to mitigate the damage caused by SARS-CoV-2. The vaccine was approved very quickly, less than 1 year after the discovery of the virus. So there is still some knowledge gaps after the approval of the emergency approval of this vaccine. So the vaccine effectiveness studies has this whole of fill these knowledge gaps, such as outcomes of interest, the more uncommon ones, such as severe disease and death, the effectiveness in subpopulation excluded from participation in trials, the duration of protection for vaccines, and the effectiveness against new variants. With that in mind, my main objectives are to evaluate the effectiveness of COVID-19 vaccines employed in Brazil, analyzing the outcomes of symptomatic infection, hospitalization, admission to intensive care unit, and death. And I have 4 specific objectives: to assess the influence of the aging and effectiveness of COVID-19 vaccines, to evaluate the duration of protection offered by COVID-19 vaccines, to estimate the effectiveness offered by booster doses of COVID-19 vaccines, and to investigate the effectiveness of COVID-19 vaccines in individuals previously infected by the SARS-CoV-2 virus. My methods are, we use the data sets of the 3 surveillance systems previously explained. The SUS Notifica, which contain data on suspected and confirmed 19 cases, and the also clinical and demographic data. The CVAP GRIP, which contain data of hospitalization in the ICU and deaths due to SARS. It also contains clinical and demographic data, and the PNE about the COVID-19 vaccination data. We linked these data sets through a deterministic way, using a crypto key provided by DataSUS. We only evaluate individuals aged 18 years or more, and the COVID-19 cases are considered only if it has laboratory confirmation. One of our study design was the retrospective cohort in a format of a dynamic cohort, in which participants can change the exposure group with time and dose, exemplified by this graph, where we can show the start of follow-up at the day of the first dose, and after 13 days, it goes from the unexposed to partially vaccinated, and if an individual took a second dose, past 13 days of this date, it can go to full primary series. We use the unexposed group as a proxy for the unvaccinated, because we don't have data, direct data on unvaccinated individuals. And these are no assumption, as there is no protective effect from vaccine in this time window of 2 weeks after the first dose. The general inclusion criteria are individuals without evidence of previous SARS-CoV-2 infection at the date of the first dose. We also employed all the time scales, such as calendar time, to adjust to a better adjustment for changes in health policies and the variants over time during the pandemic. And all models for the statistical analysis for this type of study, we use the negative binomial regression and the Poisson regression. Our analyses are conducted in a safe environment, assessed only by accredited research. Our data manipulation and the analysis are conducted using R, and the study was approved by CONEP. So, our first question for this thesis is, what is the COVID-19 vaccine effectiveness in the Brazilian population? And what is the impact of age on the effectiveness? This resulted in a paper published in the Illustrated Journal Health Americas. It was a retrospective cohort from January 18 to July 24 of 2021. It comprises close to 75 million of individuals, among them 25 vaccinated with coronavac and 50 million vaccinated with Shadox. the outcomes evaluated were infection, hospitalization, ICU admission, and death. And we used the negative binomial for this paper. Here we can see a summary of the results showing the two groups, vaccinated with coronavac and vaccinated with Shadox. I'm showing the vaccine effectiveness for the full primary series. That's it, individuals past 2 weeks after the second dose. The results are stratified by outcome and by age, with the lighter colors indicating the younger individuals and the darker colors the older individuals. We can see a stronger protection against the severe outcomes in both vaccines, but there is a lower vaccine protection in older people. Here is exemplified by the case of coronavac decaying after the 8th decade of life, and for Shadox after the 9th decade of life. These results are consistent with the literature, or results of the overall vaccine effectiveness, with the paper from Chile, Indonesia, showing a vaccine effectiveness against hospitalization of ranging from 71 to 87. In your case, it was 71 for hospitalization. In the case of Shadox, our results are very close to the paper conducted by Bernal and colleagues in England, which found a VE of 95 against hospitalization, and it was 91. Regarding the decay with age, it is also present in the literature, despite the difference in the amount of the decay with age, as the paper from Hazan and colleagues show a decrease from 77, between 70 to 74 years old, to less than 40% after the 80 years old. And for our results of coronavac, it decreased to 58 in the 8th decade of life and 42 after the 9th decade of life. It is also seen, the same pattern is seen for individuals vaccinated with Shadox, and also in other vaccines, such as the influenza vaccines, which exhibits a low protection in older people. We can hypothesize the mechanism implicated in this type of decay of being responsible, such as the immunosenescence and the inflammation, which are changes in the immune system through aging, characterized by the decrease in naive B and T cells, decrease in antibody production, and the increase in dysfunctional memory cells, and a chronic state of low-grade inflammation. The first three are characteristic from the immunosenescence, and the last one for the inflammation. Because of that, some studies have evaluated specific strategies for the elderly subpopulation, such as the change in the antigenic concentration for vaccines or the number of stimuli for the subgroup. Moreover, in the same paper, we glimpsed probably waning of effectiveness after time after the second dose, as exemplified in these cumulative incidence curves. We can see a change in the rate of the events in the last half of the follow-up time in the older individuals. So the next question is, how long does the protection from COVID-19 vaccination last? And it resulted in two papers, one published in The Lancet using data from Shadox, and another published in the Nature Medicine about the individuals with mild series of coronavac. In these two papers, we used the on-mod type of study design, the test negative case control, and we select individuals who seek medical care and classify them as cases those who test positive for COVID-19, and the control those who test negative for COVID-19. And we compared the odds for vaccination in these two subgroups. It says a very robust test design, study design for evaluate vaccine effectiveness, because it minimizes the selection bias due to differential healthcare seeking behavior between vaccinated and the unvaccinated individuals. Our general inclusion criteria for this type of study was individuals tested with RT-PCR or lateral flow within 10 days of disease onset. For the statistical analysis of this type of study, we use the logistic regression, using 3 different frameworks: the generalized linear model, the conditional, or the generalized additive model. Going back to the papers, the paper from Shadox was conducted from January 18 to October 25 of 2021. We use the test negative case control to evaluate the estimate the V against symptomatic infection, and we use the retrospective cohort to estimate the protection against severe outcomes. In this study design, we use the Poisson model. The study comprises close to 42 million of individuals with 2 doses of Shadox. And for CoronaVac, we only employed the test negative case control for the mild and the severe disease. It was conducted from January 18 to November 11. In this study, we also include individuals with previous SARS-CoV-2 infection, but adjusting for this factor in the model. And these results are comprised for close to 7 million individuals, most of them being controls. Here you can see a summary of the results of the 2 papers: the vaccine effectiveness over time against symptomatic infection of individuals vaccinated with Shadox and individuals vaccinated with CoronaVac. We see a peak of vaccine effectiveness after 2 weeks after the second dose, going up to 30 days after the second dose. And the passage time, we see a decline in the vaccine effectiveness for both groups. In relation to the protection against hospitalization or death, in the case of the paper from Shadox, we used this period of the peak of protection, 2 to 3 weeks, as the reference group, and we compared the rate of events in the other time periods. We see a clear increase in all age groups, but we see a more less rate ratios, smaller rate ratios in the older group, the 80 years or more, but it probably reflects the high baseline risk in these age groups as compared to the others. In the case of CoronaVac, as we used the test negative case control, we could directly estimate the vaccine effectiveness. So we see the same pattern of a peak in the 2 to 4 weeks after the second dose, and after that we see a decline in the protection. So to sum up, there is a waning of protection against symptomatic infection and severe outcomes after the second dose. It is consistent with other results, as the case of the paper from Shadox. It was conducted together with the team from Scotland, and they found similar results with a harmonized methodology. But also other groups found the same pattern of the decline of the vaccine effectiveness after the second dose, but in different degrees of the waning. Here is exemplified by the paper from England, found a decline from 67 to 44, and the paper study conducted in Sweden, there is a decline from 63 to no protection against symptomatic infection after 17 weeks. The same behavior is seen against hospitalization. There is different amount of waning, but there is waning in all papers evaluated. In the case of CoronaVac, there is a scarcity of studies conducted for this vaccine. Here I'm showing 2 of them. Against symptomatic infection, a study conducted in Malaysia found a decline from 74 to 30% after 4 months of the second dose. And another paper conducted in Brazil by Hit and colleagues found a odds ratio of close to 2, comparing individuals vaccinated 6 months ago with the second dose with those vaccinated between 14 to 41 days. As I have said before, the Ministry of Health in Brazil recommended a booster dose in individuals after September. So the paper from CoronaVac, which was conducted from up to November 11, we could estimate this protection of the booster dose. Here I'm showing them. We see a clear protection rebound, and it will reach high values of protection earlier after the booster in all ages and in both outcomes. So we see protection close to 95% in the younger individuals, up to 80% in the more older. However, after the emergence of the Omicron, we see a huge surge of cases. So it probably could reflect a different vaccine effectiveness against this new variant, the Omicron, compared to the Gamma and Delta period. So following this hypothesis, our next question is, what is the protection offered by booster doses during the Omicron period? And it resulted in 2 papers, one already published in the Nature Communications, using individuals with the primary series of CoronaVac, and another only under review at the PLOS Medicine, using individuals vaccinated with BNT or Shadox as the primary series. Both of them were test negative case control. In the case of CoronaVac, it was from January 1st to April 17th of 2022. We evaluated the outcomes of symptomatic infection, hospitalization, and death, the composite of hospitalization, death, and the individual wounds. The study comprised for close to 2 million and a half. In this case, most of the individuals are positive, test positive, compared to the study conducted during the Gamma and Delta, where most of the individuals were controlled. For the study of Shadox and BNT, it was conducted from January 1st to April 23. We evaluated the vaccine effectiveness against symptomatic infection, only against the composite outcome of hospitalization or death. It was comprised by close to 5 million individuals. Here we can see the summary of these 2 papers showing the vaccine effectiveness against symptomatic infection over time. We see a clear trend in all vaccinees with a moderate level of protection after 2 weeks after the booster dose, and a marked decline after 4 months of this booster dose, reaching negligible levels of protection. In the case of the protection against hospitalization or death, the picture is very different. We see a sustained protection against these outcomes, which we see a slight degree decay of protection in the individuals aged 80 years or more, decline from 80% to 73%. The similar behavior seen in individuals vaccinated with the primary series of Shadox and BNT and the booster dose of BNT. There's a sustained protection, and only a small decrease in the older group, the declining from 90% to 80%. Sum up, there's an increase in protection against hospitalization or death, with a slight decay over time in older people. These results are consistent with the literature. As previous, our paper from Shadox are conducted in collaboration with the Scotland team, and they found similar results. But also in other groups, it also find only a moderate level of protection against symptomatic infection after the booster dose, but a sustained high level of protection against hospitalization, both in primary series of CoronaVac or BNT. In the immunological aspects of the booster dose, we can see an increase in immune response after the third dose, where we can see neutralizing antibodies against the Omicron after the third dose. But in studies evaluating the immune response after the fourth dose, we only see a small increase. So there's possible cap in the number of stimuli to increase the immune response. But in some one additional dose can improve the protection against severe outcomes. There is a case of the very different, as we see, there's a very different rate of the decay in the protection against symptomatic infection and the sustained protection against severe outcomes, which probably reflect the different immunological mechanisms for the two outcomes. As the cellular immunity is associated with the protection against severe disease, and it has a high cross-reactivity, so it can respond to mutations in the virus, and the humoral immunity, which is for blocking acquisition of infection, but it has a little cross-reactivity. As you can see in this chart, showing the relevance of each mechanism, immunological mechanism for protection against these outcomes. So the antibodies are more associated with the protection against asymptomatic infection, and the T cells against the death. With that in mind, there is a need for continuous monitoring of vaccine effectiveness, especially in clinical risk groups. So to recapitulate what you've seen up to now, there is a low protection by vaccine in older individuals. There is a waning of effectiveness against symptomatic infection and severe outcomes after the second dose. There is a short-lived protection of the mRNA booster dose against Omicron infection, and the booster dose increases the protection in a sustained way against severe outcomes. My next objective of the thesis is evaluate the effect of previous SARS-CoV-2 infection on vaccine effectiveness. We published 2 papers about this topic, both of them in the Lancet Infectious Disease. Of note, the second one, vaccination plus previous infection, was among the editor choices in the volume. Both of them are test negative case control. The first one are conducted during the Gamma and Delta period. That's it, before December of 2021. It was conducted from January 18 to November 11. The inclusion criteria for this type of study, individual must have evidence of previous SARS-CoV-2 infection, where we consider a positive RT-PCR or lateral flow test with a difference of 90 days before the first test and the second test. For this study, we used a matching design. We have matching by age, plus minus 5 years, sex, city, and testing day, plus minus 10 days. For this study, we comprised close to 100,000 individuals, most of them being controls, because it was before the Omicron surge. In the case of the study conducted for Omicron, it was conducted from January 1st to March 22 of March 22 of 2022. The same inclusion criteria are employed, and we studied close to 900,000 of individuals, most of them being cases. Here you can see a summary of both papers, showing the effectiveness, the additional protection of vaccine. So in this graph, you are seeing the compared individuals with a hybrid immunity. That's it. It has a previous infection plus vaccination against individuals only with the previous infection. We see additional protection for vaccines, individuals previously infected, both in the Gamma and Delta period and the Omicron period. We see a more robust protection after the full primary series during the Gamma and Delta, and also during the Omicron period, but in a smaller degree than before. Now comparing the same individuals against the naive unvaccinated, that's it, individuals unvaccinated without a previous infection, we see a sustained protection of the previous infection against severe outcomes. That's it, higher than 80%. But this protection can be enhanced by vaccine dose. As you can see, some individuals with the vaccination and previous infection have VE closer to 100%. But against symptomatic infection, there's a decay, there's a waning over time also. These results are consistent with the literature of the hybrid immunity. Here I'm showing the results from paper evaluating against unvaccinated with a previous infection. During the pre-Omicron, there is only additional protection of close to 50% against severe outcomes in the paper from United States. And the Omicron, the same study found a protection only of 37%. For symptomatic infection, it also a decline in the amount of additional protection offered by vaccines during the Omicron era. In the case of we can call absolute protection against the reinfection, we see a sustained protection from only the previous infection during the pre-Omicron, with levels higher than 70%, depending on the study count. And the hybrid immunity of infection plus vaccination higher than 80%. But this is changed by the Omicron. As you can see, the previous infection alone has a estimated protection of only 40 or 50%, but it's remain protective against the severe outcomes. Both in the studies conducted in Qatar and in Canada, which show a very robust finding because these two countries have very different socioeconomic structures, with Qatar being majority by individuals being male and the younger individuals, and in Canada being a more general population. So we can say there is strong and durable protection from previous infection against severe outcomes. There is low protection against Omicron infection, and this protection can be enhanced by a vaccine dose. This knowledge is relevant because it can optimize the dosage in a scenario of low supply of vaccines. As any study, we have some limitations. As our observational study, we had the risk of unmeasured confound, aggravated by the use of previous stability surveillance system, which lack some important covariates, such as the socioeconomic status. But because we used this previous stability surveillance system, we could quickly produce information. We didn't have direct data on unvaccinated individuals using the retrospective cohort. One strategy to bypass this problem is using the total population minus the number of vaccinated individuals as the unvaccinated. However, we have a very outdated census data. The last one is from 2010, so it could induce some major bias in the number of populations for using this type of strategy. We didn't have data on sensitivity or specificity of the diagnostic tests, which is a problem because the assumption of the perfect test on the test negative case control. Because with these parameters, we could adjust in the model. But as the studies are performed in two countries, Brazil and Scotland, in some papers, using similar methodologies, we minimize the risk of spurious results due to systematic bias. In conclusion, our COVID-19 vaccines are effective against severe disease. This protection decays over time with emergence of new variants. Additional dose with mRNA vaccine strengthens the protection against severe outcomes during the study period. COVID-19 vaccines offer temporary protection against symptomatic infection, including individuals with booster mRNA vaccine doses. Older people showed worse vaccine effectiveness than younger individuals, which suggests that new vaccines should consider the characteristic of the senile immune system. Individuals with a previous SARS-CoV-2 infection maintain a higher level of protection against severe outcomes, which can be enhanced by vaccination. It is necessary to monitor vaccine effectiveness to detect early signs of loss of protection, especially against severe outcomes, considering the potential for emerging new variants. And digital health, such as surveillance system, can generate robust information for public health planning. I would like to thank all the Viva team, led by Barros and my supervisor Viviane Boaventura, the members Vinícius Araújo, Eni Paixão, José Bertolo, Pilar Veras, Maurício Barreto, Guilherme, Gerson Pena, the international collaborators such as Neil Peace from the London School, Vital from the University of Glasgow, Aziz from the University of Edinburgh, and Chris Hobson. And thank you, everyone.
Thank you, Thiago, for your presentation. We will start the questions with Dr. Heather Whitaker. She's a PhD in epidemiology and public health at Imperial College London. She's a senior statistician of the UK Health Security Agency, and her area of research is medical statistics, especially in epidemiology. So she has been working on infectious disease epidemiology, delivering robust tools for epidemiologists to study vaccine safety and effectiveness. Thank you for joining us, Dr. Heather Whitaker.
Thank you so much for the invitation to examine this PhD. It's a real pleasure. It's a fantastic amount of work that you've done, and you should be really proud of what you've achieved. And in so little time, I mean, I think these 7 papers we see, they must have come out in the space of just over 1 year. So that's a big achievement. Well done. So I'll just start with a little bit of kind of general background on you. I'd like to know a little bit more. So what is your background? What was your first degree, and how did you come to work on COVID-19 vaccine effectiveness?
Okay, my first degree is, I'm a medical doctor from the same university, but I always like the quantitative methods and the statistical in biostatistics. So I have started to work with the biostatistics since the beginning of my medical school. And I started working with the chikungunya with Professor Viviane Boaventura, and also with Professor Barros. And since the start of the pandemic, we changed our focus to the COVID-19. We started using, developing a telescreening service, such as the telecoronavirus, which individuals could call for help, asking about the symptoms, and it was severe or not severe disease. It was running by medical students and supervised by physicians. So we had this type of interaction with digital health. And soon after the approval of COVID-19 vaccines in Brazil, Professor Barros was responsible to monitor a group of monitoring the effectiveness. And he kindly asked me I wanted to join in this group, so I started to work in COVID-19.
Yeah. Excellent. So paper 1 was the very first vaccine effectiveness study you've ever carried out, is that correct?
Yes.
Yes, yeah. Okay. So kind of beginning with paper 1, what was your particular role in this study, and how did that fit in with the role of the rest of the team that you worked with?
My role in the first study, I'm to develop the methods used to estimate the vaccine effectiveness, and conduct all the analysis in the draft the first paper, the first manuscript in this paper.
And then as we kind of move through all the way to looking at the booster doses, how did that kind of your particular role in the study team change over that period?
As I'm going more knowledge about the statistical methods using in this type of analysis, and the knowledge about the COVID-19 vaccines and the bias implicated in this type of studies, and so I'm got more autonomy, so I'm more responsible to draft all the paper and using the input of the other members. So in some of the papers, I come with the idea for the evaluation in which groups. So there's this change over time.
Okay, so you were kind of leading the questions as well as design and writing.
Yes.
Yeah, excellent. So going back to paper 1, so the methods in paper 1, they're quite different to the methods in paper 2, but they're both longitudinal studies. I think if you were to go back now and redesign paper 1, but say keeping it as a longitudinal study, is there anything about the methods that you might change?
I probably want to use the first the unexposed group as the comparison group, because it can do some type of bias. There are some healthy vaccinees bias where individuals are asked to be healthy during the first dose, so we have some type of bias in this type of study. So I probably only would estimate waning of effectiveness, such as the second paper, instead of true vaccine effectiveness as we used it in the first paper.
Yeah, excellent. Yeah, so I think I agree. I mean, I think I was concerned at seeing certainly like day 0 in the reference period. That would kind of certainly a day when we know that people were healthy and they went to get their vaccinations. I mean, do you think we could have perhaps further restricted the period to something more reasonable, or?
I think we could use the 3 to 90 days or 3 to 10 days, as most of the papers will show this type of health vaccine bias only the first 3 or 4 days of them. Yeah,
that's exactly what I found when I was looking at vaccine effectiveness too. Talk to me about how you adjusted for time in paper 1. I think I was a little bit confused as I was reading it.
In the paper 1, we used the month of the first dose for vaccines, so they are justified by time in this paper as only by month of the first dose, but we also adjusted for the RT in each the first day in each exposure group, so you could estimate the change in the force of infection. But I agree the adjustment by time in the first paper is less optimized than the second one.
Yeah, absolutely, I agree with that. So I noticed that clinical risk status wasn't adjusted for. Was it just simply not available?
Not available. We only had data in the test negative.
Okay, yeah, okay. And I don't think it was mentioned that hospitalization or death needed to be within a particular window of a first positive test. So did you take all of the hospitalizations and deaths, or was there some kind of restriction around the test times?
We didn't test it for test time in the first 2 papers, but in Brazil, the system who provide the data from hospitalization death is the SARS, the CVAP grip, and they only has data from SARS cases. So it is more very unlikely the incidental hospitalization or death we using this type of data. We only had it.
So how did you deal with, say, like repeat hospital admissions?
In the first 2 papers, we only consider the first admission to.
In the first paper. Okay. So let's move on to paper 2. So what were the advantages of working in collaboration with colleagues in Scotland?
We can triangulate the results as we are working 2 different counts, because we didn't keep combining the data. We only was it different. So this type of analysis, we can compare the results and see it has problem by bias or not. And you have very different types of data. The Scotland team has a very rich data about the multiple comorbidities and the other characteristics not available in Brazil, but they have very small numbers compared to Brazil. So we have the power of Brazil and the sensitivity of the Scotland in this type of work constantly.
Okay. And so you found some differences in the results between Scotland and Brazil. Were there any particular results that yourself and the team found really hard to explain, or could you find reasons for most of the differences?
In the paper 2, I think you could find the reason for most of the difference, because they be estimated in the paper 2 we used the 0 to 13 days in Brazil, while in Scotland it was truly unvaccinated, and there are the differences about the amount of rate ratios, not the direction, one thing like that. Okay,
good. So there was one strange thing which kind of surprised me. So I think, let me see. So I'll just read a little thing out. So repeating vaccine effectiveness analysis for Scotland using the same reference period and more limited adjustment as in Brazil suggested that vaccine effectiveness is likely to be consistently underestimated in Brazil. I think this really surprised me, because we know we have this kind of period of low risk in those first 13 days after the first dose. So it's a low risk period, and I would have expected to see an overestimation. I just wondered if you can kind of have any ideas why you saw an underestimation.
Because we are using this time window as the reference period, and there is low risk in this period. The other periods we have a lower vaccine effectiveness compared to them, because they are including the individuals with the low risk. Is that?
Yeah, I wonder. Maybe it's to do with the adjustments made. I don't know. Anyway, let's move on to paper 3. So here we change to the test negative design. So why did you choose a test negative design over a cohort study here? Do you think there are any particular advantages?
Yes, mostly because we did have data on unvaccinated in the cohort design.
Yeah.
And the data sets for using the test negative design, we can look at comorbidities, which are a major factor for severe disease in the vaccine effectiveness. So this has this conjunct of benefits for the test negative design. So we started to use that, and we didn't drop that.
Okay. So I was just wondering about what non-COVID events your hospitalization and deaths data set are likely to contain, and why it's suitable for a test negative design.
The non-COVID-19 deaths and hospitalization are because influenza and the other respiratory virus circulating in Brazil, but we included that as control, and the vaccine effectiveness, we compare the test negative of all individuals, not only the hospitalized, to estimate the vaccine effectiveness. So there's not much bias in this type.
Yeah. Did you consider separating hospitalizations and deaths into separate analysis?
In this paper, we conducted the conjointly and separately, only hospitalization, only death too.
Okay.
Only in one paper, we only provided this type of a composite outcome as the last one, about when of a booster dose in BNT Shadox. Our others are provided separately.
Okay, so did it make much difference if they were separated or included together?
No, they are very close, the results.
Oh, that's amazing. Okay, it's kind of reassuring.
Mm-hmm.
Yeah. So let's see, move on to paper 4 and paper 5. So, yes, now we're looking at the individuals with the past infection. Okay, so this time you used a matched test negative design. So why did you choose a matched design, and what do you think of the pros and cons of matching versus adjustment?
The most suggestion of other colleagues in this paper, we worked with another team of the vaccine effectiveness studies in Brazil, and I found it very robust because you could adjust by city of individuals, as Brazil has over 5,000 of cities. In the match design, you can use this type of adjustment because it does not go direct in the model. So there's this type of a benefit, and also we could test different matching strategies and compare the results for check the robustness of the finding.
Yeah, I think in the paper 5, you didn't find much difference between matching and adjustment. Is that right?
Yes.
Yeah. So in paper 4, you looked at protection within the first 6 days as a test of bias and found that Coronavac had a positive association in that period. What do you think that indicated?
This case of the Coronavac vaccine I think it's probably biased. I couldn't find a very reasonable explication because they 7 to 30 days it don't have this type of a positive effect. So it's probably because they have a vaccine bias in this analysis for the.
Yeah, it's possible. I mean, I did wonder as well because the immune response is probably faster when it's boosting a previous infection, and actually it might be true that there is some protection in those first 6 days, but I'm not sure either.
But it was for the quickly response because we are boosting individual. It was should appear at least 7 to 30, 15 days. It did not appear indeed.
Yeah. Do you think it would have been possible even to use a cohort design for this study?
Yes, we kind of conduct a study in this type of a design using a nested case control, using all individuals who have the previous SARS-CoV-2 infection, is checking for the second event. So it's possible to use this type of analysis.
Good. So you found some odd results where the vaccine effectiveness was higher, 90 plus days post the ChAdOx1 vaccine than it was at 14 to 90 days. Do you think there was any reason for that, or do you think it might have just been a chance finding?
Could you remind me where this finding is? I don't remember by head where.
Yeah, that's fine. So in the discussion, it was indicated that Brazil hadn't had as large an increase in hospitalization and deaths over the Delta period as other countries. So why do you think that might have been the case? Any ideas?
Probably because Brazil had a very high number of cases during the first period of the pandemic, and it probably under-notified cases. So we had already a pretty large number of individuals with immunity. So when Delta arrived, there is not the much explosion of cases.
And one question on paper 5. So I think paper 5 ends with this really interesting point as to whether future efforts should be focusing on symptomatic infection or severe disease as SARS-CoV-2 becomes endemic. I'm just wondering if you have any particular opinion on that.
Yes, I'm on the team to evaluate more severe disease than symptomatic disease, because it's very difficult to trace individuals with symptomatic, and the testing policy has changed over time. Already in much country there is no large mass testing, so it's difficult to conduct studies evaluating, I guess, symptomatic disease. But severe outcomes is different. Is very difficult to under-assessment severe outcomes. All individuals must seek a hospital or medical care, and we can track this individual.
So moving on to paper 6, where we're looking at the waning protection. So for the first time in this paper, we start to see some lower vaccine effectiveness in the younger age groups against the symptomatic infection. I mean, do you have any ideas as to why you saw that?
Yes, there are some theories about contact detergent in which individuals vaccinated have more contact than unvaccinated individuals. But I also think about the under-assessment of a previous infection.
Yeah.
Also, it says already in the Omicron period in Brazil, we didn't have enough tests for everyone. So I think most of the unvaccinated were positive, but not tested before.
Okay. Yeah, excellent. Good. Actually, my next question was entirely about that, about the under-ascertainment of cases. Actually, we have kind of the same situation in the UK because mass testing actually ended in the spring, and now we have an autumn booster programme. So do you think, I mean, now that we kind of really don't know who's been infected and who hasn't been infected, so when we do our future vaccine effectiveness studies, do you think we can, or even whether we should, adjust the past infection in them?
I think after the Omicron and this very large surge of cases, is not reasonable adjust for previous infection, because they don't have this information, more sound information about that.
Yeah, I agree with you. Thank you. And then paper 7, so that was another one that you did with co-authors in Scotland. So here, I mean, I think the difference between the other paper with Scotland is that you had different variants over the periods. For this paper, paper 7, you had the same variants, but still you found lower VE in Brazil than you did in Scotland. So have you got any ideas as to why you think it was lower in Brazil than in Scotland?
We found a lower VE against symptomatic infection in this paper. It's probably because of the under-assessment, because in Scotland they didn't have this problem during the Omicron. They had the readily available tests. In Brazil, we didn't have that. So I did a post hoc analysis using only previous infected individuals for this paper, comparing the VE. are similar to the paper 4 and 5, and they find values more closer to the found in Scotland, in Brazil, the overall in Brazil.
Okay. So then moving on to your discussion, I was really interested to read about your kind of future ideas for research, and it's fantastic to, you know, see that you have those ideas and to know that you're going to be continuing in this area. And I was just, one little question was what study design you're intending to use for your future research, looking at those longer term effects of infection?
I think it was in the cohort study design for this longer time, but for confining the increased risk of individuals after COVID-19, I think he used the self-case controlled series because it's about the limited time we can look the increased risk. So you can confirm the outcomes of interest was the self-case controlled series and the effect of vaccine mitigate those risks in the cohort design. Ah,
interesting. Okay. I was expecting you'd say a survival analysis, but yeah, could use self-control case series too. Yeah. Okay. Fantastic. I think that's the end of all of my questions. I just want to say well done again. It's really a phenomenal amount of research that you've done, and absolutely brilliant how much kind of, you know, you've contributed to knowledge of vaccine effectiveness. Thank you.
Thank you very much.
Thank you for your questions, Dr. Hilter. I'm going to move to Dr. Jennifer Dan. She has an MD and PhD at Boston University. She's an infectious disease physician and in immunology, and works with as an assistant professor at the University of California, San Diego, and also as a researcher from the La Jolla Institute for Allergy and Immunology. Her area of research is immune response against infectious disease. Her studies have provided a huge contribution to the comprehension of the duration and the characteristics of the cellular immune response after SARS-CoV-2 infection and after vaccination against COVID-19. So thank you, Dr. Jennifer Dan.
Hi. Yeah, that was a lot of work. It was great. So I'm used to looking at vaccine immunogenicity. So you had brought up the idea of protection against infection versus protection against severe disease. What do you think about these different vaccine platforms or SARS-CoV-2? Like, I mean, the idea was to elicit, protection against infection, but now we're obviously looking at something quite different. I guess, what do you think about that? And what do you think about other vaccines in terms of protection against infection and protection against severe disease?
There's this difference in the immunological potential for these very different platforms. The mRNA being more potent in immune stimuli, but the inactivated vaccine has more diversity of antigens and the epitopes. So I think the barrier of the both words would be a primary booster, a primary dose with the coronavac to very overall epitope repertoire, and the booster with mRNA vaccines. So we can combine the repertoire with the immunology stimuli.
So so which platform do you think is better than the coronavac with the mRNA booster, either Pfizer or Moderna? You think those would be the best one versus Okay. And then in terms of some of the studies, I think the first study separated hospitalization and ICU for adverse or severe outcomes, but I think the second and third study didn't separate hospitalization and ICU. I was curious if you had that data for those two studies, just from a personal experience, like seeing patients, like transplant patients, like I see solid organ transplant patients, and when they get into the hospital, we hospitalized them in the beginning of COVID because they just had COVID and they were otherwise okay. And then of course there were some that actually did require oxygen and required hospitalization, but the indication for hospitalization normally should be, I need oxygen or I need some sort of support. So I was just curious, were you able to tease that out when you're looking at vaccine effectiveness? Because I just know that we, in the beginning, hospitalized because we know you're a transplant patient, you're immunosuppressed, we're scared what's going to happen.
Yes, in Brazil, we have a very particular type of the healthcare system. So we have the UPAs with it, like a emergency department, and some of the treatment is going in this type of the healthcare facilities, and the only more severe cases going to hospital. So only individuals requiring oxygen or any other advanced medical treatment going to the hospital. So our type of analysis for hospitalization was robust in this type, and also because the severe grip is only for SARS-CoV, the individual must have a definition of SARS for be entering the system. So our hospitalization for us is a SARS definition. So have this in mind.
Okay. And then when you talked about when you're thinking about the platforms for vaccines and coronavac being better in terms of there's more epitopes because it's a inactivated virus. I was curious, when we make an immune response with an epitope, it's based on our HLA. How is our HLA going to respond? How are we going to make a response to something? Did you ever stratify based on race and ethnicity? Because the HLAs track a little with that. So I was just curious in terms of vaccine effectiveness for prevention against infection versus for prevention against infection. That would be the main, interesting point from it, I think.
Yeah, we didn't think about stratifying by race, but in the first papers, the paper would choose the cohort design. There's the problem because the race going from the SCPNE data, not from the self-referred during the test. So it is very there's huge mistakes in this type of data from race. So we could not use this data for race, but as a good hypothesis of stratify by race and look at the difference in the effectiveness.
Yeah. Okay. And then this has always been one of those main questions for, I guess, a lot of immunologists. What do you think, like you look at the different platforms, what do you think the duration you should wait between doses? I mean, Janssen was 1, but what's the best duration? Because coronavac was like 4 weeks, right? And then Pfizer is 3 weeks and Moderna is 4 weeks and Novavax is 12 weeks. Yeah. What was the best duration to wait? I know they're different vaccine platforms, so it's going to be a little different, but
in Brazil, we started the coronavac with 4 weeks, but in some trials used 2 weeks between the dose. And for Shadox, we used the 12 weeks and also 12 weeks for Pfizer in the beginning. But after a time, it goes to 2 weeks in Brazil. We did look specifically for this time window between the first dose and second, but you look for the second dose and the booster dose. We see a longer waiting, more than 4 months apart, is better for the immune response than 3 months apart. But we didn't publish this finding. But we did look at that, and we see an increase in the effectiveness after 4 or 5 months apart. And there are some papers looking at the antibody dynamics and see the same pattern of a longer interval between the doses provide a better immune response.
Yeah. Okay. Yeah, we think it's because of the germinal center response peaks at day 21, and there's no point in giving another vaccine when you're not going to change too much of it. But yeah, I mean, that's great. And then did you look at vaccine effectiveness or duration longer than 120 days? I was just curious. I mean, I think that's always one of our questions. What is the duration of protection? And I know, like on your Nature Communications paper, you looked at it for 120 days. In the heterologous vaccination study. Did you look any further than 4 months?
For this case, we did have enough data for look at more than past time point, and we still don't have the data to look at this time point. But for the primary series, there are colleague look at this longer period, and he's found the same the decay, smaller decay in the longer periods, 240 days, 1 year after. They reach a plateau level of protection, very small, and the decay very slight over time.
Okay. And then looking at all this, if you were to make a recommendation to the health ministry about when should someone get a booster vaccine? Like every government has their own recommendations, but what would you say after doing all these studies? When should someone get a booster vaccine?
First, you stratify this recommendation by age group. So individuals younger than 60 years old could be 5 months apart. And after this time point, after this age, 4 months apart. Not considering new variants, because we have a surge of a variant, we could provide a booster for everyone after 4 months.
Okay. I'm trying to think of something else. Yeah, sorry, I can't think of something right now. I'll think about it. Hold on. Thank you. That was great.
Thank you.
Thank you, Jane, for your questions and comments. It's been really a pleasure to have all of you here, and it's a committee formed mainly by women, and we're going to have the next one that is Dr. Cristina Ribeiro de Barros Cardoso. She has PhD in Basic and Applied Immunology at University of São Paulo, and she's currently an Associate Professor of Immunology and Neuroimmune Endocrinology at the Faculty of Pharmaceutical Science of Ribeirão Preto, that is in the University of São Paulo. And she works with immune inflammation and also, as I said, immunoendocrinology. And recently, she has been investigating the mechanisms behind the different risks from human and men to develop severe COVID-19. So thank you, Dr. Cristina, for joining us.
Okay, I think now it worked.
Yes.
Are you hearing me? Yes?
Yes, yes.
I was not being able to turn on my microphone. So thank you, Viviane. Thank you, Thiago, and all post-graduation course for inviting me. And it was a pleasure to analyze your work. And it was a pleasure also to meet everyone here. I didn't meet before. So Thiago, you did a very nice work. I was thinking about how many hours a day you slept because maybe you didn't sleep. How could you work and write 7 excellent papers in so short time? It's I think you have also a great group, right?
Mm-hmm.
And everybody working together. It's very important. And considering the Brazilian situation on pandemic, I think your work is very, very important because we that we live in Brazil and we know what we passed during the worst times of the pandemic and the negation on the science and people who didn't want to get vaccine and people saying that coronavac didn't work and so on. We know we had lots of troubles here. I think in the other countries too, but I don't know how, the extent of this science negation and the other countries, but here it was really, really difficult. And it is until today. For example, we are having, I don't want to enter in this theme, but we are on the São Paulo state. I don't know if our foreign colleagues know that we are on time of politics change in Brazil, and for example, in São Paulo state, we have probably we will have a new how can I say manager, governador, and that is not he doesn't want to vaccine for everybody, so we don't know what is going to be on the next years if he wants the election, because he doesn't agree with vaccination. So what is going on? So I think your work is very, very nice on that. And I have a few questions that I will try not to repeat the first questions that our colleagues already did. So before that, I only would like to reiterate my congratulations for you and all your team. It was really a nice, very good work. The first question is related to exactly to the situation we were talking before. So we know that during all this time of pandemic, we are facing some difficulties in having trustful data from Brazilian government, and sometimes data, there are some disappearance of data and data come back, and we have some delays on the notifications. And for example, we had a huge problem on some months ago. I don't know if you remember that, about the notification of vaccinations date with AstraZeneca Shadox vaccine. And there was a discrepancy between the data people had the vaccine, the real data, and the data it was notified on the system. So my question is, how trustful, I know you already published your papers, you have very good journals, but how trustful you think these data are, considering the difficulties we are having on the assessment of the Brazilian data and governmental data and notifications and so on?
So we had some strategies to check this quality of data. So first one, we cross-checking the variables present in the multiple systems. So if an individual are marked 40 years old in system, all the systems also not have the same age. So if it has not met, we would exclude this individual. For vaccination, we also check the chronological number of doses and the dose registered in the system. So if a second dose are registered before the first dose, we also excluded this individual from the analysis, and we do that for our papers. So in the case of the delay of the notification during the first most of the 2021, we restricted the analysis for 1 month, with 2 to 4 weeks before the date of the last update of the database. So we only was the case registered 2 weeks ago or 4 weeks ago. So we could not have a huge number of cases delayed of the notification. These are the type of analysis we use to check the robustness of the data. And it always found a very high degree of concordance, the cross-checking, and the number of excluded individuals for this mismatch between vaccination doses and the chronological doses are very small, so it can be sure about the data. But the problem of the access to data is present. So now we don't have more access to the data. So it's,
okay. It's very interesting because, for example, when you look at the data on the, you know that the APP connect SUS, connect SUS, I think it's SUS connect SUS, where when you can look for your own vaccination the day you had the vaccine, and if you had 2 or 3 doses and 4. For example, my own vaccination information is wrong when I look at that. So, you know, there are some inconsistencies, unfortunately, but I think you worked correctly on that, so you can handle it. I'd like to know if you, for example, we had already discussed here the difficulties on having the exact information about the infection, if people really got infected or not because of the symptoms. Many people, it's not, we can believe, unbelievable sometimes, but many people don't know how to report their symptoms. Some people have symptoms and they don't know it's not a COVID-19 symptom. I have nose something and sore throat, a weak sore throat. It's not COVID. So we hear it every time in Brazil. So it's very, very common. No, it's just allergy. It's very, very common. And also we had the question about the asymptomatic people, because we can have a lot of people that is asymptomatic and doesn't even get a test. So how do you think you managed this? I know we already discussed it, but do you think it could have had an impact on your results?
It could have impacted the first paper, where we used the cohort for evaluating infection, because in this case of the asymptomatic and the undetected infection, we could compare those individuals with all the individuals, the vaccinated individuals who are more health care seeking, so any symptom they seek medical care. But after this paper, as we are using the test negative for symptomatic infection, the type of selection in the test negative of only people with similar symptoms seeking medical care, and looking the vaccination in those people prevent most of this type of bias from asymptomatic and the individuals who are not testing because they think the symptoms do not match with the COVID-19. So these are a very robust of the test negative design.
Okay. Do you know the second article? I read that the Scotland data was corrected, adjusted for obesity, right?
Yes.
But not the Brazilian data.
Yes.
I think it's not easy to have this information. Do you know how was it managed in Scotland, and if it could have, in some way, differed your results from Brazil and Scotland? Because we know that obesity is one of the main comorbidities associated with COVID-19 aggravation and worst outcomes.
One of the sensitive analysis performed by the Scotland team was in the same minimal set of confounders, and it is excluding the comorbidities because in Brazil we didn't have comorbidities to check if the findings are similar. So I don't think there was difference because the presence of this data about the comorbidities in the results, but it lacked the precision because we didn't have enough data of the comorbidities in general. In Scotland, they have the BMI of each individual, as it has the general physician data of each individual, so it has very rich data.
Yes, it would be very nice if we had all this information here. And so the other question I had is, it would be very desirable if we had the samples of at least part of these patients, right? Of this, you have all the demographic and epidemiological data, but no biological samples of these patients, right? And do you think, is there any possibility of accessing another kind of data of these patients, of these vaccinated individuals? For example, the hospital records of these patients, for example, medication used, or some blood tests, or something like that? Or can you look, for example, in your data, in your bank of data, is there any possibility of looking for specific regions, hospitals, and or no? Is it not possible?
We can look at specific hospital,
Okay,
because
yeah.
the KINES is the number. We can look at the hospital. About the specific individuals is very difficult because we don't have any identifiable data, as this is
Yes,
changed to a crypto key during the data source.
because of ethics and so on.
Yes, but we have some projects of try to cross-link the rede genômica from Fiocruz, the data from those samples with the data from the samples of this type of database. So we could look at the severity by genotype of the virus, but the type of all the laboratory tests, I think is very difficult to obtain.
Yes, we had access here on the, I don't know if you have already heard about the FAPESP data bank at São Paulo State, that we have some laboratorial data from Fleury laboratories and the Syro-Libanese hospital, and also I guess it was Einstein Hospital. And so we have a lot of data, of laboratory data of these patients, but it's not a so huge cohort like yours. So maybe you could look at that, something. Thiago, but coming back here, in your opinion, it's just for you to think about something. What would be more desirable? You have a vaccine that would avoid the symptomatic infection, and so you could manage better the transmission and control the overall pandemic and the cases, new cases, and the possibility of virus mutation because of high transmission rates, or a vaccine that would prevent severe cases. So we know it's very hard to have a vaccine sterilizing immunity, but do you think it would be possible? What do you think it would be most desirable.
Yeah, either was, I think it prevented the infection, the infection, even the asymptomatic infection. So there is no invisible transmission between individuals. But I think it's a very utopic goal, because even the most recent trials evaluating the vaccine is using the Omicron as the base. They didn't find a very high level of effectiveness, and even the titers of the neutralized antibodies using this type of vaccine, Omicron based, compared to the ancestral based, is very close on another. So I think it's a very impossible to have a vaccine which prevents infection. So it's better to stick with the I guess the severe cases and the need less number of doses, because it could also make a exhaustion of the immune system at the multiple number of stimuli. So.
Yes, it's not an easy task. Coming back to the coronavac studies, when we had the results from the efficacy studies in Brazil, there was a huge difference between the efficacy studies in Turkey and less in Chile, right? So what do you think, why it happened? Because we had the same technology, and you discussed something in your thesis, but I'd like to hear about you. What do you think about that? Why coronavac had so less impact on Brazilian patients, on Brazilian population, than in Turkish or in Chile?
First, about the difference in the
efficacy, not efficiency.
The efficacy of the Turkey and the Brazilian study, I think Turkey was close to 80%.
Yes, higher efficacy, much higher. It was surprising.
It can be possible linked to ancestrality, because there is difference by the mounted immune system, the antibody against the epitopes by ancestrality, and also the difference in health policy. So in Brazil, didn't have a federal health policy against COVID-19, have a federal health policy in favor of COVID-19.
Yes.
But I don't know if in Turkey, I didn't look at that, but I think in Turkey, it's against COVID-19. So this type of difference in the baseline risk of the individuals during the study period impacted the estimated vaccine efficacy. So I think the major difference between the two countries is the type of baseline risk in those more in Brazil, because the difference in policies. So more individuals are exposed to the virus. We didn't have any lockdown, and any tentative of the shutdown was try to I don't know, boycottado, and tentative shutdown in Brazil. So I think it is this type of baseline risk included.
But do you think that we could have a role for auto-medication, self-treatment of Brazilian population because of the high levels of using ivermectin, chloroquine, antibiotics without medical prescription, or even with medical prescription, we know that it happens. And because we know also we had a interference on, for example, antibiotics. A lot of people had antibiotics in Brazil for treating COVID-19, azithromycin. It was very, very common, unfortunately, and we know it affects all your microbiota, and this affects the immune responses and so on. And do you think we could have an impact of these false cures for COVID-19 that were largely prescribed in Brazil before and after vaccination? So what would be the impact of this? Because I think it was different from the other countries. Brazil, we had a lot of fake news and fake distribution of medicines and treatments. And it was very, very widely distributed. So do you think it would have any impact on these studies of vaccination and immunity and all the characterization of the Brazilian outcome in the pandemic?
I think about the efficacy study, this type of off-label medication could not impact it very much because the control of the study individuals during the efficacy study. But in the effectiveness study, as we are looking at the real-world impact, this type of medication has a immunological impact, so it could decrease the effectiveness of a previous good vaccine. So there's this type of problem, and also because the sense of the notion of these individuals not need to seek medical care, they only need the self-medication. But also this impact more the cohort studies evaluating infection, because the individual had the choice to seek or not seek medical care to be tested. But in the case of hospitalization, the individual don't have this option unless the medical the hospital using another code for the COVID-19 as also was presented in Brazil. And in the case of the test negative, it is minimized because some population who seek medical care are being evaluated. So it's unlike an individual who uses this type of medications, seek medical care for a very mild symptom, and the change over time and the started to seek medical care. So I think this problem present in Brazil is a major impact for cohort studies because this type of bias which can be presented. I think it is that the major problem in Brazil.
Okay. And what about the sexual difference, men against women? Because we are studying here, Viviane knows the difference between sex. So men are more susceptible to COVID-19, and while women are more susceptible apparently to the long COVID and the sequelae of COVID-19. You wrote many times in your thesis about the males are more susceptible, and as I think you adjusted it, right? Or
yeah,
as a confounding factor.
Mm-hmm.
But have you looked at specifically at the difference of males and females on the efficiency of vaccination and all the protocols and the analysis you made? If you can say, for example, And in women, vaccine, a booster of messenger RNA vaccine is better than in men. So do you know, can you affirm something like that?
No, I can affirm this type of sentence, but because we didn't look specifically for each sex, we could we could estimate that, but I didn't think before.
Do you agree with me that it's different when you use it as a confounding factor and you make the adjustment, the statistical adjustments, and when you look at it without adjusting the other confounding factors, but not sex as a confounding factor?
Yes, we did use it as an interference factor in the interaction factor with vaccination, vaccine effectiveness, and it is some studies who looked at in this type of interaction and found a difference between effectiveness in male and the female. I think it also entered as a limitation in our study because we didn't look at this type of interaction.
But do you have any plan of doing that or no? Of looking at for?
I think we can look at that, but for
it's not your
same of historical perspective, because the data source cut off all data. So
okay, so Thiago, I think I have only one last question. I will not repeat other questions I had that the previous examinators already did for you. What do you think will happen from now in Brazil specifically? Because do you have the pandemic is over or almost over here? Are we safe? Do you think we will have new variants of concern or novel vaccines, maybe updated vaccines? What will be the frequency? What do you think would be the frequency and the plan for vaccination against COVID-19 from now on the next months and years? And what do you think will be our situation here from 2023 and so on?
First, for the VOC aspect, we need to look at it worldwide because we only can prevent the emergence of new VOCs if there's a equal distribution of vaccines across the world. So there is not hotspot of new variants in the world, and we exported these variants for other countries. And I think the situation of vaccines for COVID-19 will be very close to of influenza, which has a yearly vaccination against influenza, but I don't know if it has a yearly updated vaccine. But because after Omicron, we did not see updated vaccine with greater effectiveness, but there is also some tests going on, such as nasal vaccine and the other types of vaccines against COVID-19, which should provide more knowledge about that and the better platforms to deal with this disease. But I think we will have our yearly vaccination against COVID-19, and it probably will target the older individuals, as an influenza vaccination campaign, but it's very dependent of the more equal distribution of vaccines across the world, because there is still some countries with less than 10% of fully vaccinated individuals, so it can emerge a new variant more severe and more transmissible in fall. There is these assumptions of the method.
So we still have a pathway to walk on, right?
Yeah.
Okay, so thank you, Thiago. Thank you very much.
Thank you.
You really did an excellent work. And I'd like to congratulate you again and your family because they give you your support, and your supervisor and your group and everybody. So I desire you have success in your professional life from now and on, more success, because a thesis with 7 very good papers is not an easy task. So you did more than most of the students do. So congratulations and good luck for you in the next studies.
Thank you very much.
Thank you, Cristina, for your comments. And for after all, I will discuss a little bit about some topics. But
and I'd like to look for the difference in males and females. Okay, Thiago, you want?
Yeah, sure.
I'd like to talk to you later after the phases.
An additional question from Jennifer that she just remembered, and she put it on the chat. Thiago, if you could answer, she's related to if you would recommend changes based on the data of vaccine effectiveness for severe outcomes.
Change in. Can you read it again, please? I did have.
Oh, it's Jennifer, if you can say, but would you recommend changes based on your data recommendations about the vaccine effectiveness probably about the boosters? Is that correct, Jennifer? Because of your data of protection against severe disease.
Yes, I probably would, because we are rolling a second booster dose in various countries, and some countries, this booster dose has been provided for everyone. So younger individuals are taking the booster dose, so I probably restricted this case to only individuals aged 60 years or more, or another age cutoff, or presence of comorbidities implicated with a decrease in the effectiveness, such as immunosuppression or diabetes or other type of comorbidities.
All right. Oh, okay. Thank you. I was just referring to, like, sorry, when I asked of, like, if you were to make recommendations to the health department, and I think you had said for just preventing infection, maybe you would recommend like 5 months for individuals who are over 80 versus, 5 months for individuals who are younger, I guess less than 80 or less than 60, and then individuals who are over 60. 5 months, I guess, or hold on, 4 months for getting the booster. But then if you look at your vaccine effectiveness, when you're looking at severe outcomes, it's the effectiveness is so much higher. Would you change that recommendation of boosting? Would you just instead because if your goal with the vaccine would be to prevent against severe infections, I guess in this scenario we're preventing it against severe infections, would you change your duration for the Department of Public Health? Or
this interval is from the second dose. I have said as from second dose to the booster dose, because I had a paper look specifically for that. So you see the individuals who are boosted 3 months apart, the second the booster has a lower effectiveness than the boosted 4 months apart. So individuals with a second dose more than 4 months ago to the older, and for the younger, as this only decrease after 5 or 6 months, it will receive another vaccine shot. Also because we can provide some residual protection for infection, even it's waning very quickly, so it can reduce the transmissibility a little bit. So the recommendation for these 2 points, the more certain protection for the the severe disease case and the residual protection for the symptomatic infection.
All right. So you would still keep it at 5 months for less than 60 and 4 months for over 60.
Isso, between the second dose and the booster.
Okay, thank you.
Okay, now let's move on for the last professor, Professor Jamary Oliveira Filho. He has PhD in neurology in University of São Paulo. He is a neurologist and has master's degree in epidemiology at Harvard School of Public Health. So currently he is the head professor of neuroscience and at the Institute of Health Science of the Federal University of Bahia, and also a professor from the Faculty of Medicine of Bahia.
Well, thank you, Viviane. It's a pleasure of mine to examine Thiago. And I really liked the previous examiners here, the question lines, and I thank you very much because it's nice to learn from everyone, different backgrounds, so it helps a lot to get a sense of how different specialities look into the same subject. I think Heather Whitaker, she started with a different approach, asking what Thiago's background was, and I think he responded pretty well. But I must emphasize in regards to how much he has accomplished over such a short period, that he started this as a medical student. So he just recently graduated, so it's even more impressive that he was able to perform so well while being in medical school. He was a student of ours, and a brilliant student as a medical student, and so applied into this research field that he was able to accomplish so much while being in 2 research groups. So these 7 studies were performed in one research group, but he also contributed to other studies in my research group while he was there. So it was that's pretty amazing that he was able to accomplish both with such care. So that's incredible. So firstly, congratulations, Thiago, on this accomplishment. I really have very, very few things to say because I participated in the first phase of the qualification. So this for this postgraduate program, we have a qualification phase where some people in the evaluators, some evaluators can be shared between the qualification and the final thesis defense. So I already had time with Thiago to contribute with my suggestions in the final version of the thesis, and all of these were changed, and I think some improvements were made in the final version, but it was already very good in the first version. So we had a few contributions in the first phase, but now I have even less contributions to make on the second phase. I think also the previous evaluators made a lot of the questions that I would have. So about the interval, the ideal interval between the doses, from the data that you gathered in the 7 studies. So you've answered that pretty well. Christina's question about the quality of the data that we're also always worried about when we're talking about Brazilian databases, but I guess any country has limitations when you collect data from millions of people. But the question about coronavac efficacy different in our country than other countries brings up all of the subject about how public policy played a role in decreasing efficacy of any intervention in Brazil-wide. So that was very interesting there. One of the comments that you might want to go back to your final thesis format is that in the original version, the qualification version, it was all written in Portuguese, and the articles obviously were in English. But it was originally made in Portuguese, and I see that you had all the trouble to translate everything to English so everyone could understand. That's pretty amazing. But some of it remained in Portuguese, mixing Portuguese with English. So there are some tables, for example, that there's in the title of the table, there's study design period, and the next phrase is desfechos avaliados in Portuguese. So you might go back and and see if you actually translated everything, or some copy and pasting didn't make it through the translation process. So just take a look at that, and it'll be fine. Yeah, the essence of the thesis is there, and I think most people who read your thesis will understand all of it because the articles are already published, and certainly all the Brazilian people reading it will understand. So you made a good job out of it. And I guess the only thing that I brought up in your qualification that I want to hear from you a little more from how you dealt with it is the question about the methodology itself for the test negative case control, where one of the main issues around it is the potential for misclassification due to the multiple test strategies that you had to deal with. So, for example, there are different time periods where you accept the PCR results or antigen tests, or which have different sensitivities and specificities to define what is a test positive and what is a test negative. And how did you deal with that? I would like to listen to your comments.
During the first period, the 2021, most of the tests performed in Brazil are RT-PCR tests. So we could use only RT-PCR as in our running analysis, as the paper from Coronavac and the first of previous infection, and we use this type of analysis. But after some period, Brazil has changed swiftly from RT-PCR to lateral flow tests. So we have a mixture of lateral flow and the RT-PCR. To deal with this difference between the sensitivity of each test, we performed the analysis using all tests, or using only RT-PCR or only lateral flow tests. So we could compare the results for each type of test. In the paper from Nature Communications, we have this in the supplementary table, the every outcome for each type of test. So we see a difference in the symptomatic infection using this type of the only RT-PCR or only lateral flow. There's the outcome with more difference between 10 to 20 points, depending of the age group and the period. But for severe diseases, it is very close in all outcomes and the all ages group. Go ahead.
So it didn't change. It didn't change the overall study results, basically, when you compared, independently of how you defined your test positive or test negative results, right?
Yes, it remains the same pattern. We say the same when there is when, or the same sustained protection when it has sustained. So it wouldn't change all results. We don't change the number, the point estimated for the value.
And that's very comforting, because makes the study results more robust. So, and Viviane, I don't think I have any further questions. I mean, since I participated in the last phase, and all the remainder of the examiners already asked most of my questions, I guess I'm very well satisfied with the answers that Thiago provided to us. So I'm left with congratulating yourself, Viviane, for the brilliant orientation, I think, for the advisorship, and Thiago and his family for such a nice and competent delivery of a thesis exam. So,
thank you very much.
Thank you, Jamary. So the last speech is mine as a supervisor, and I will let Dr. Manuel Barral, if he wants, to talk a little bit after that. Just some brief comments about what was said here regarding the question of either to increase the delta, why we didn't have an increase in delta cases in Brazil, just as occurred in the rest of the world. This is probably because we had a great and big wave of gamma infection just before and almost concomitant to the wave of delta. So probably the people were like, had a booster with delta if they survive it. And then we had a protection. Of course, this influenced in the way the delta wave occurred in Brazil. So about Jennifer's comment on the best schedule for vaccination, we have evaluated a combination of vaccine schemes and schedules, and we found that it's interesting is that heterologous booster seems better than homologous one, even using BNT. We didn't publish these results, but we have these data, and this is an interesting finding. So regarding the concerns of Cristina about the quality of the data, these was an additional challenge to evaluate the quality of all these data in this situation that were like changing constantly, and we had to perform several sensitive analyses just to address that kind of problem. Of course, we have, we admit that we may have incorrect information for some patients, and we do work with what it's nice about working with a big database is that when you have like 212 million patients to people to evaluate, we assume that those errors may occur, but they may not have a big impact on the final findings. So the other point is using different methodological tools, we got robust results that were like reproducible in other countries. About Jamary's comment, I think he had great contributions for the thesis and also for the helping Thiago become a good statistician in addition to a good physician, because he was also his professor during the medical school. I really want in the end to really thank all the Vigivac team. That was a rich discussion, and the results are important for, we got relevant questions with that insights and that discussions, and these intense and great work is really a result of this group. Like we had a really great work together, and all these months that were very intense and important to have this outcome.
Everyone as the privilege together.
Yeah, and we have also others papers that Thiago also joined it. It's from Vigivac, but also from chikungunya and for leishmania, and he had a great job in all these studies of the group. I'll say a few words about Thiago. He's an exceptional student and with a great capacity of self-learning. He wanted to, actually he had the past years, in addition to the thesis, Thiago did a lot of jobs in other areas of study that has nothing to do. His initial study was not related to vaccine effectiveness, actually it was related to chikungunya. And when we became with the questions of how to get these kind of information that we want, Thiago rapidly found tools, interesting ways to answer the questions. And this was amazing. So it was a great pleasure to have Thiago as a PhD student and work together all these years. I think maybe Dr. Manuel, as a co-advisor, wants to make some comments. I'm gonna turn on your microphone. You can go on.
Well, thank you. It's really a pleasure just to comment. That was, I mean, very good to work with Viviane that I know for a long time. And with Thiago, that is, like Viviane said, is very dedicated and very capable and worked a lot to put all these studies together and with very high level of stringency and criticism on the work. So he's really an exceptional student and now exceptional doctor and MD PhD from now on. And congratulations to both of you and to the whole team of Viva that you said, because we had several good inputs in the discussions and in planning the work. So it's just that, I mean, just congratulations.
Yeah, that's all. I think we can move now for the second section. I'm gonna open another room so we can move as just the committee. And then you can stay here, the other people, and then you come back. Let me see. I should take Thiago out of the, but he can be. Let me. Okay. You have to, yeah.
I have to move to.
Oh, I'm sorry, I was muted. So I'm gonna read the minute and then we can finish the section. So today is October 14 of 2022, and we started at 12 o'clock and 3 minutes p.m. Remotely via platform Zoom. This is a session of the program of post-graduation course in health science at the Faculty of Medicine, Bahia and Federal University of Bahia. So the public section began to discuss and defend the thesis entitled Digital Health for Monitoring the Effectiveness of Vaccine Against COVID-19 in Brazil. And that was presented by the graduate student Thiago Cerqueira Silva. The examining committee approved the postgraduate program college in health science as established by the general regulation of the postgraduate course of the Federal University of Bahia, and the regulation of the postgraduate program in health science of the Faculty of Medicine of Bahia was composed by me, Dr. Viviane Boaventura, with PhD in human pathology, as a president, Dr. Jamary Oliveira as a neurologist, and Dr. Cristina Ribeiro as a specialist in basic and applied immunology, and Dr. Whitaker as an epidemiologist and a specialist in epidemiology and public health, and Dr. Jennifer Dan as a doctor in immunology and microbiology from the University of San Francisco. So after presentation of the thesis, the examining committee carried out the argument that was answered satisfactorily by the doctoral student. The thesis presented was considered passed, and to be part of the process of completing the course of the graduation, the examining committee drew up these minutes, which are signed by all the members. The examining committee approved the thesis with no recommendation of modification to the final version. Actually, there's a little modification that you need to do that's related to the translation of the document to English in some parts as appointed by Dr. Jamary. So congratulations, Thiago, for your brilliant division and work. And thank you for everybody for being here. If you may want to say some words, I have to allow you to speak. Wait a minute. We did this because we didn't want to get interruptions, but I think it's not a good idea to like mute everybody automatically.
You can mute Thiago, I think. Also. Thank you, everyone. This past, I think, 8 years, consider my medical school is very, some years being very tough in the beginning of the medical school, but after my joining in the research world, it's going to be better, and it has been increasingly more satisfactory each year. It is increasing my networking with more collaboration, more people working in more interesting questions to seek the answer. So it's a very pleasure to work with Professor Boaventura and the Professor Barros, and also Professor Jamary, Oliveira, Filho, with during my medical school in a total different topic of the stroke and the cerebrovascular activity, very different from my previous project from PhD from immunopathogens of chikungunya. And so I'm very multiple areas of knowledge during the same PhD, MD, PhD. So thank you, everyone. Thank you. I'm very grateful for everything.
Thank you, doing this. We can end this section. So have a nice weekend, everybody.